Good morning, everyone. I'd like to point out that I, like Philomena, have my own technical advisory group. It's a global BEP technical advisory group. And BEP, in case you haven't figured out by now, it's balanced energy protein supplementation, which can be fortified with multiple micronutrients, or it can be given along a multiple micronutrient tablet. So let's dive in. All right, so today I'll walk you through the acceptability definitions, the evidence that's published, and a few case studies, including one from Ethiopia, and then some conclusions for practice. So from prior evidence from WHO, we have a definition that indicates that acceptability relates to the respect for medical ethics, cultural appropriate, and sensitivity to gender. The World Health Organization has a definition for acceptability. It's quite general. It includes people, programs, health facilities. Everything needs to be people-centered, so we need to worry about our patients. And in addition to that, we need to have to cater for the specific needs of diverse populations, and we need to do that in accordance with the international standards of medical ethics for confidentiality and informed consent. We as a team came up with a definition for acceptability, specifically for pregnant women who are maybe taking MMS or iron and folic acid. And we indicated that acceptability is the comprehensive assessment of pregnant women's willingness and satisfaction in integrating MMS in their daily lives. And it should have several components. It should consider organoleptic properties such as taste, size, color, appearance, and so on. It should be easy to consume, so we need to think about how easy it is to swallow. And we need to think about side effects, so we need a good intervention that reduces those side effects. In addition, we need to be considerate of the individual and cultural beliefs and the preferences of the supplement. So what do women want? And we need to do all of this keeping in mind the socioeconomic considerations of the specific area. So like I said, I'll walk you through some of the evidence. We have very little evidence on acceptability of MMS versus iron and folic acid, specifically in pregnant women. And as you can see, there are two published studies, one from Nigeria and one in Mali, and one will be published soon. So my colleague Monica Fox could tell you more about it. The new study will be published by her and her colleagues. And then there are three non-published case studies. So we collaborate with several investigators, including Ramadani here in the room, to give us some evidence for this current presentation. So I'll present some case studies from Cambodia, a refugee called Anra in Jordan, and the data from Ethiopia. So let's start. First, the published evidence. I selected one study. This was published a few years ago in 2004. But it was an effectiveness study, included 70 pregnant women, equal number in each group, and the intervention was given in sachets of 90 tablets, equally for each group. And we can see for the properties of the supplement that women liked equally, actually, the MMS and the iron and folic acid with respect to taste, with respect to size and color. But you can see 89% didn't like the smell of either of these supplements. And regarding side effects, they equally said that they had some vomiting, nausea, dizziness, headaches. But interestingly, the supplementation was given during pregnancy and lactation. And look at that. Women reported none of these side effects during the lactation period. So it makes us wonder, is it the pregnancy side effects or the supplements? In addition, another important consideration is to give good and simple instructions to women how to take the supplements. So in the study, we can see very simple instructions from the health workers. So the women received the intervention at home, and they were told, take one tablet and one only, daily for the benefit of herself and mother and baby. Take the tablet before going to bed to minimize the side effects. Take them with a glass of water and keep the tablet out of the reach of children. Regarding perceived benefits or facilitators, we can see both groups, so MMS and IFA, they claim these supplements eliminated some of the pregnancy-related side effects. They reported benefits for the mom and the baby, and the majority of them said it was easy to remember to take the supplement on the daily basis. And 60% said their family, so husbands or community members, helped them to remind them to take the supplement. Regarding barriers, the study identified that 82% of women did not know the cause of anemia, and 30% did not know the consequences of anemia. So those are important things to address. Regarding, I'd like to specify one more thing here. So the remaining of the women who were encouraged, so some 60% were encouraged, but 35% were neither encouraged nor discouraged, and then 5% were absolutely discouraged to not take these supplements. So that was for either supplement. Now, let's go to the first case study from Cambodia, which used an unblinded cluster randomized non-inferiority trial. It's a bigger study, so it included 48 centers. And the intervention, there were 3 arms, so 1 iron and folic acid, and 2 with MMS, but the quantity of the tablets is given in 2 separate bottles. So in the first group, we have all the tablets given at once in 180 tablets, and in the second group, we see women received once the 90 tablets, and again, another time the rest of the 90 tablets. And what did these women say? Well, for this study in particular, more women in the MMS group versus the iron folic acid said they mentioned that they like the smell and they like the taste. But we see a difference there. So more in the MMS than the iron folic acid group. With side effects, these women reported more side effects in the iron folic acid group than in the MMS group. And I've listed them here. There's typical side effects that I mentioned previously. But interestingly, this study looked at side effects over time, and they reported less side effects as pregnancy was ongoing and as they were taking more of these supplements. So they need to keep taking them. It's also important, like I said with the prior study, to receive consistent and clear messages from the health workers. So here again, the women were told, take 1 tablet and only 1 daily for the benefit of her mom and baby. Oh, this is the wrong slide, I apologize. They received information, but simpler. Supplements are good for the health of the mother and baby. They heal the baby strong and smart. And then they were told to take every night this tablet before going to bed. With regards to perceived benefits and facilitators, we see more benefits from the MMS, from women who were in the MMS versus iron folic acid group, and they reported they had more energy, they felt happier, they had better sleep, they liked the MMS packaging, and they felt less burdened to take the supplement, so they were not burdened by taking the supplement. And equally between groups, we see negative perceptions or barriers regarding taste of the supplement and smell, and they did not like to pay. They saw that as a barrier, so they did not want to pay for the supplement. Now, moving on to the refugee study from UNRWA, which is conducted in Jordan in Palestinian refugees. So they did a 10-month systems trial design. They had 13 clinics where women received iron and folic acid, but also folic acid, and another 13 clinics which they received MMS. And you can see the packaging differed. So in the first group with iron folic acid, they received those supplements in blister packs, versus the MMS was 180 count tablet. For the properties of taste, smell, and so on, we see women actually dislike the MMS smell and taste more in the MMS than iron folic acid. And for side effects, we observed less side effects in the MMS than iron and folic acid. So we can see the supplement MMS led to 73% of women to say they had no stomach upset or constipation. So that is good news. Regarding perceived barriers, and benefits and facilitators, we see for facilitators that MMS was perceived better than iron folic acid. So women were more energetic, they felt happier, and they had an improved appetite. And for barriers, we see that women didn't like the smell of MMS more than that of iron folic acid. And going on to the last case study from Ethiopia, my colleague Ramadan is here somewhere, so if you have more questions for him, you know who to ask, but I'll do my best to summarize what he found. So this used market research mixed methods cross-sectional design. It included 5 regions across the country, 410 pregnant women for this particular acceptability work. So as you can imagine, they didn't interview all women in the regions, and they gave either iron and folic acid or the MMS. And they reported that the taste and smell and color was better with the MMS than iron and folic acid. And side effects, there were more with the iron and folic acid than the MMS. For perceived benefits or facilitators, we see more. Women reported more of those for the MMS than iron and folic acid. And they indicated that they had a positive pregnancy experience and they had a healthy baby. So that was more in the MMS than iron and folic acid. And for negative perceptions, this was across all groups. So we can see that they did not like the counseling service. They said they were poor. And the study actually also interviewed the health staff. So they indicated they are overwhelmed. And in addition to that, women also reported that a barrier was the fact that they had to get to the health facility and the cost associated with that. So they have many other things to do, and now you're asking them to go to the healthcare center, and when the services aren't good, women are not happy to go again. So we need to make sure they go again. And this study also indicated that women received a negative influence from their husbands and all elderly women, and that I heard from other teams here. So now, let's put it all together and understand what is the take-home message. So what should we do? So we need to consider the tablet size to make sure it's easy to swallow. And ideally, it should have no smell and taste. So we need to work with the food manufacturers there. And women need to receive very simple messages that convey the positive effects for mom and baby, but also instructions how to take the supplements. They need to be short, but they need to be simple. And we need to address cultural rumors and misconceptions. So I can tell you from some of these studies I was reading that some women were even thinking that MMS is a contraceptive. So it's very opposite from what MMS can do. And we need to educate health staff, community leaders, and husbands to address those negative rumors. And we need to do that with sensitive and culturally appropriate materials. And last, women prefer the home delivery. So that's probably true, particularly in rural versus urban areas. So the intervention, the delivery of the intervention probably needs to differ depending how far these women live from a health center. And last, women preferred either a low cost or a free MMS. So to the extent possible, we need to make this intervention free for them.